Welcome, ladies and gentlemen, to this, the October board of the Wye Valley Trust. I'm delighted that we're now able to invite members of the public to join us live on YouTube. Please do give us feedback on how you find this format. Obviously, in a world of COVID-19, we as a board are continuing to do everything we can to protect our staff and our patients and their families. Hence, we are continuing to hold effectively all of our meetings digitally. One of the great advantages of that is it does allow us to invite members of the public who perhaps find it difficult to get to the hospital-based board meetings to join us through the wonders of digital technology. But please do give us any feedback. And equally, if you want to ask a question, if you can do so by emailing Erica Herman, whose details are available on the website, you're able to ask us questions. And indeed, later on, we have one from our good friend at Health Watch, Chris. So we look forward to that later. We have apologies for absence from John Barnes, who is on a well-deserved break before the challenges of winter approaches. Do we have any new declarations of interest? Please come off mute if there are.
Russell, can I give apologies for Andrew? I thought he'd let you know, but he did tell me he can't make the board meeting. Andrew Cottam.
That's great, thank you. And I was aware of that. Thank you, Frank. And equally, I'm conscious of the fact that some board directors may need to pop out of the board meeting, and we'll duly note that if that needs to happen. But thank you, Frank. So the minutes of the meeting held on the 3rd of September, was everyone happy with the accuracy of those minutes? Please come off mute if you're not happy. Okay, thank you. So on that basis, I'll accept those as accurate and I'll duly sign them. If we can go to page 14 of the board pack, we have the actions update. And the first was for the communications team to ensure that the message is sent out to the media to inform patients of the importance of staying on the waiting list and self-isolating prior to their procedure. That has all been done, hasn't it, Jane? And is part of a very comprehensive communication package which Jane is overseeing, which includes communication to staff, communication to members of the public about the importance of the flu vaccine program this year. And I really would encourage members of the public to have a flu jab this year. This year is the most important year, given the challenges the NHS is facing on COVID-19, for you to have a flu jab. On the Chief Executive's report, we had the Audit Committee to consider the implications of the Independent Medicines and Medical Devices Safety Review by Baroness Cumberledge. That we'll come back to that later, Glenn. And then on the finance plan, that would be presented to a future board meeting, and that's on our private board agenda later. But Glenn will be touching on some of the challenges the NHS is having at the moment with its finances and the new ways of looking at financial rewards providers being considered. Then under the future activity performance reports, to include the comparison of cancer performance with those elsewhere in the Midlands. That's going to be covered off later. So thank you, John, in absentia, for sorting that. And then Lucy to review the cleaning contract with the performance data, which shows reduced level of performance. That's covered in the quality report. Lucy, anything you want to add at this stage?
Yeah, it was that the data was missing from the quality indicators rather than a deterioration. So the report will cover that in my section. Thank you.
Super, thank you, Lucy. And then Andrew to provide an update at the next Audit Committee report regarding the discussions held in September about the Trust's expenditure on COVID-19. Frank is going to cover that off later, but it is included within the body of the report. Then we had some actions in progress. Howard will review how typical the substantive medical staff additional payments are and compare these with other trusts. We're imminently expecting the result of that out, so anything could happen in the next half hour, so used to sound stingrays, so keep us briefed as that develops. And then on the COVID update, the more information around routine specialities. We'll be talking about COVID in today's board meetings, members of the public, but that will be covered off in the winter planning report due in November. Are there any matters arising that I've missed? Are colleagues happy to move on, therefore? So, Glenn, please give us your summary.
Good afternoon. So, start of my report now, I talk about the developments of COVID and testing. I mean, obviously, members of the public will be aware, as well as board members, that we are experiencing a second wave of COVID cases. I think actually, if you look beneath the surface at the numbers, even though they look similar in terms of cases to around the peak in April, we are testing significantly more. So I think if we were testing the number of patients that we are now, we would have detected far more cases at that point. So it's not as high as that first peak, and indeed across our area and indeed the Midlands, we're starting to see a degree of plateauing, which I hope continues. I think it's well worth putting that into context with a lot of what we see on the media is the unmitigated forecast of doubling of activity if no further action is taken. So it's been encouraging to see some of the national figures starting to slow down a little bit, which is indication that the local lockdowns and some of the changes to the national rules are making a difference. So there's a kind of a plea here to members of the public that we've managed this really, really well actually in Herefordshire. There's been a great public response. If we keep doing the simple things, follow the guidance, then we can contain this and keep it safe for us and for the NHS generally, because as you can see later on in the report, we are also trying to recover a lot of services and improve waiting times at the same time. I also talked there about some innovations in elective testing. So we're using home testing kits for that. It's been a little bit bumpy as a pilot exercise, but there's now a clear pathway for those tests using Pillar 2, which is the independent sector, and a push for the NHS to use that as the testing method of choice for elective patients. And also, hopefully soon, we will get more access to rapid testing capability. That will help us to manage winter, particularly with giving us a very quick decision at the front door about whether we have COVID positive or non-COVID positive patients. Then I'll talk about the financial architecture, and Howard will talk to us about this a little bit later. It's these are very unusual times. We held into block contracts for the start of the year, and we received top-up funding to assist with COVID. But in the second half of the year, there's an attempt to try and fix the funding envelopes for systems like ours. And so we've received some more explanation of that since we last met as a board. And Howard's analysis of that is it does leave us a little bit short. And I think most trusts are feeling that it leaves them a little bit short. But there are a number of assumptions that we've made within that we'll obviously need to manage, particularly things like the use of agency staff, the recovery of waiting lists, for example. So alongside our assumptions, one of the things I think we really do need to do, and we will be doing this here, is get a very clear plan for the second half of the year that we can then articulate down to our divisions. I think there's a bit of a culture approaching that we're just hoping that systems are going to manage the money, and I refer to my worry of a system credit card approach. Within our organisation, we will issue really clear plans. There may be some risk to us as a trust in issuing those plans, but I think our budget holders, our clinicians need to understand what resources we have available. So we will do that, and that will be something that we'll bring back probably to next month's board meeting as a more detailed proposition. I then talk about recovery and restoration. We had a regional review. Our position in Herefordshire is seen as very good, and I've seen some comparative data of all of the trusts across the Midlands region, and the recovery of lots of our services has been very positive by comparison. We've obviously had to also model some scenarios going into the winter around how that recovery will continue. But there's still an aim to get through as much of that elective work as we can this side of the winter, because obviously normally in winter we have flow issues because of urgent care, and we'll be managing those as well. And then finally, I talk about valuing patients' time. We had the fantastic Wye Valley Way work last year. I describe a second exercise that is helping us to focus on that. The 4 questions that are identified there has become a regular currency of discussion with patients and on wards. And this will also, the work that I describe will help us to understand a little bit more some of the issues that came out of the inpatient survey, which identified potentially some communication challenges with discharges. So it's very much our intention to improve that with these pilots and to evaluate the impact of that. Happy to take questions.
Thank you very much, Glenn. Questions or perspectives to Glenn? Please come off mute if you have a question or perspective. So Richard first, please.
Yeah, thanks, Chairman. Glenn, I was interested in your comments about COVID. I mean, it seems to me that in Herefordshire, we're doing pretty well generally in terms of the numbers, and that's the way we want to keep it. But I think the average member of the public wouldn't necessarily know that. And the reason we're doing well is because most people are sticking to the rules and behaving sensibly. And unlike other councils, we don't seem to be kind of giving feedback to the public about that. And other councils also issue reminders about what the rules are, especially when they're becoming more complex. And I just wonder if we're missing a trick as a One Herefordshire system to actually reinforce the behaviours that we want to see and give people useful information.
Yeah, I think that's...
Thank you, Richard.
Yeah, I think that's a good challenge, Richard. I think as we increasingly position ourselves to be the lead provider in the system as well, I think we should try and take some more responsibility for doing that alongside colleagues in the local authority. But I think we have managed this well. We need to make sure we're not complacent. As you say, some of the rules change, and some very senior people get confused by the rules at times. So we do need to make sure that we get that clear articulation of the rules to the population. So it's something I'll pick up with the comms team to see if we can link more into public health colleagues in the local authority to give those more regular updates, because particularly over the winter, it'd be something we need to up our game on. Absolutely.
I think just so, Glenn, just to reinforce the point, the one thing we know about all of the COVIDs, and this is just COVID-19, is that socially distance, wash your hands, wear a face mask leads to a substantially reduced likelihood of you being able to get infected. And that's seen again in the current Australian winter, where the flu infection rates, because of the level of social distancing being applied there due to the COVID infection, has led to one of the lowest levels of flu infections on record in Australia. Just on this point, David, is there something you wanted to add? David Mowbray? Obviously not. So moving on then to Nicola.
He does, Russell. He was just muted for the first sentence.
Okay, David.
I'm not muted. Can you hear me?
I can, David.
Yeah, okay. Yeah, no, sorry. We've got the one of the lowest community prevalences for COVID currently in the country. So just to reiterate Richard's point.
No, great. And I think Lucy was showing some of the detail as well. So really, everyone has a responsibility to look after their neighbours. It's not about so much just looking after yourself. It's about looking after your neighbours, your loved ones, particularly those who are elderly, and particularly those who have got comorbidities. If you want to help others and you want to play your part in society, you have a responsibility to socially distance, wash your hands, and wear a face mask. And the other thing I'd say is that it's been sniped at by some people, but the new latest COVID app is actually the NHS COVID app. It's actually a really good app. So I'd recommend members of the public to download it. Keeping the pace going. Nicola.
Hi, yeah, sorry. Glenn, as we wrestle with the challenges of recovery and restoration, just thinking back to what we were talking about 6 months ago, are we confident that some of the ways of working that we adopted at the time and that reduction in bureaucracy, that creative thought, how confident are we now that we're still continuing to do that and actually embedding what we learned at the early days back at the beginning of this year?
Yeah, good question. And the answer to your question is generally yes. The things that we tested that proved to improve the service, we are sticking with those, and obviously we're sticking with using, for example, digital clinics because of the ongoing outbreak as well. So I think that's part of it. But there are some processes that were suspended during the first outbreak that are unfortunately being reintroduced, like funding panels for continuing healthcare, which obviously will ensure that those move as smoothly as possible. But some of the bureaucracy that was able to be manoeuvred around in the early days is creeping back in. But I think, say, encouraging staff to innovate, as I described at the end of my paper there, and to look at the best ways of treating patients. In fact, at workshop this morning, we heard about a hospital at home approach, which is helping with COVID, but is also best for patients. So we're just trying to align what's best with what's also helping during COVID. And we'll be celebrating some of that actually next month in the Fab Change Day across the NHS with some of the innovation that's gone on in Wye Valley.
Great, thank you very much, Glenn. And I can't see any other hands up. Are colleagues happy to move on to the integrated performance dashboard? Super, thank you. So over to you, Jane.
Thank you. So really just to introduce this. We've really, Glenn was saying, so we've submitted our recovery plan for the rest of the year. And so where we are now, we've got about 500 patients that have waited over a year for their treatment. Where we expect to be by the end of March is that we'll have about 200, but we're expecting that all of those will be people who've chosen not to have their treatment until the pandemic's over. There are risks to that though, so that assumes that we deliver our plan. But so far, so good. And Andy, when he comes onto the ops section, we'll talk about some of those regional comparisons that Glenn was talking about. But in particular, what's gone very well, I think, is our cancer performance. So we maintained cancer activity all of the way through the pandemic, and where we are now, particularly the 28-day faster diagnostic standard, is a really good place, and we're delivering those standards. The other thing I wanted to draw attention to, again, drawing on the presentation we had this morning from the Hospital at Home team, was the work that we're doing on integrated care with both primary care and the local authority. Before the pandemic had started, we'd already put in place 2 joint appointments with the local authority, a complex discharge team, the integrated discharge team in the hospital, and then the Home First team, which integrates all of our community services for people being discharged or having an urgent need in the community under single line management. And that stood us in really good stead to make sure that we put in place that comprehensive discharge to assess process. So under the new rules, under the new funding, everybody is funded for up to 6 weeks following their discharge at no cost to them. And that's really eased up the discharge process, which means that we've been able to reduce our length of stay, but really more importantly that people have been able to get home more quickly. And when we look at hospital-acquired functional decline, what we'd hope to see is we'll start to see some improvements in people's long-term outcomes. The other thing that we're doing as part of that, and Howard's leading on, is we're looking at what the financial impact of that is on the system. You would hope that if patients are spending less time in the most expensive bit of the system, that would have a positive financial impact on the whole system, although where that impact turns up may well not be in the place where the money is being spent. So I think that's really positive, as I say, and has held us in good stead. The other part of that is that we yesterday put in a bid to commissioners for putting in place our 2-hour community response, so that during, particularly over this winter, we can provide a better community response so patients don't have to be admitted. So eases up pressure on the hospital, and again keeps patients generally where they want to be unless they've got a really acute need. And again, what we've put in is a very integrated service. So the service specification that we've put in is right across primary care, our community services, the local authority. So it's an area where we're really at the cutting edge, I think, of delivering and developing integrated services. The last thing I wanted to talk about was around workforce, and again we had some of this in the private session this morning. So Jeffrey's put in place a comprehensive report of all of the things that are going on in that area, and we are spending a lot of time and attention on that. And one of the really positive things is our sickness rate has now dropped to the lowest it's been for a couple of years, despite COVID. One of the reasons for that is because we've been able to provide really rapid testing for our staff, for social care staff and their families if they've got any symptoms of COVID, and that's enabled people to get back to work more quickly. So in a sense, my overall summary is a very positive one. We know we've got a lot of risks going into the winter, but where we are now, I think we've got a good plan, and we're doing very well against the plan so far.
Thank you very much, Jane. Very comprehensive. Any questions or perspectives to Jane? Please come off mute if you have.
Russell, it's Chris here.
Hi, Chris.
Hello. Yeah, I'm interested. Obviously, it's personal choice, the 200 patients or so that might be still waiting. But if they then all of a sudden say in May next year, right, I'm ready now, do they still have to take their turn then? Will it be triaged?
Well, they all stay on the waiting list.
Yes.
The national rules are probably going to change slightly, so that we'll have 2 parts to the waiting list, those who want to be treated and those who want to wait. But they will all stay on the waiting list. So we'll know where they are in their journey. So my expectation is that we would prioritise those who've been waiting a really long time at the point where they say they're happy to have their treatment.
Even though somebody else may be sicker?
Sorry, obviously clinical priority would always come.
Okay,
first. Yeah.
Thank you.
And any other questions to Jane, or shall we dive into the detail? Okay, thank you, Jane. I think just to re-emphasise to members of the public, some really super work going on in terms of integrating the services across the whole of the region. And as part of the Hereford and Worcester Integrated Care System, Jane is playing a pivotal role in trying to ensure that the system adjusts to the new challenges. And a really interesting presentation this morning from our hospital and home team, illustrating the way we can actually save money across the system, as Jane was indicating, whilst really improving things for patients and their families. So Lucy, over to you, please, on the quality side.
Thank you. Good afternoon. Just a few areas to highlight from my perspective. Firstly, to say the much improved serious incident position that we have with incidents open or incidents that were overdue with our commissioners, a much improved position this month in comparison to earlier this year. And just to note really that the patient safety strategy, the National Patient Safety Strategy, was launched earlier this year, and then some elements of the pilots of that were delayed due to COVID. But we do know that the new safety strategy focuses heavily on engagement, training, and an overhaul of systems and processes. And we touched on that at Quality Committee last week. And we'll be bringing the safety strategy and the Cumberledge report back to a board workshop in the forthcoming months. I'm pleased to report that we're making progress and getting some traction now around working with primary care networks and with domiciliary care around moisture-associated skin damage. We have indeed developed an education package for domiciliary care workers, and that's been implemented and training given. And we're also working with primary care to develop the prescribing formulary to change that so that patients can access the appropriate products that they require when being cared for in their own homes. Patient Experience Committee met earlier this week, and the focus was around valuing patients' time. Glenn touched on that in his report. So frontline teams have decided what it is that they want to do to value patients' time and improve experience, but the focus is very much on communication and engagement with patients and their families, and in particular looking at that around our discharge processes. And we're working really closely with Healthwatch. So during the next week, we'll be sending an adapted national survey, but our local survey, adapted from the national survey, out to patients who were discharged from our care in the last 2 weeks to ask them questions about their experience, and then Healthwatch will follow up with phone calls to those individuals to understand in more detail their experiences of care at Wye Valley. Patients who received care in our emergency department during the month of September will be surveyed in the forthcoming weeks, and the CQC will publish that report in the summer of next year. I have included in the report a little bit of detail around our cleaning standards, given the discussion at board last month. All it was that the detail wasn't pulled through into the performance indicators, but as you can see, we monitor that on a monthly basis through Infection Prevention Control Committee, and it's a good picture in relation to those standards. I'm going to take the staffing element of the report as read, but would just want to highlight that we are seeing an increasing number of patients with complex mental health needs coming into our acute services and our community hospitals, particularly in the last month. And I know from talking to colleagues in the region that other hospitals are seeing that too. And I do wonder if some of that is the impact of COVID and those individuals perhaps during lockdown not being able to access the mental health services that they perhaps needed, and that they're now in more crisis than they may have previously experienced. This month's deep dive, very much, we've touched on it already, it was around a quality priority that we set before COVID, but still an important priority, which is around reducing length of stay for patients in our acute hospital beds and increasing the proportion of patients who are discharged to their normal place of residence. And we had a deep dive of that at Quality Committee last week. It's still pertinent, even though it was a quality priority that was set pre-COVID. And I think what COVID did was allow us to approach discharge and overhaul our approach to discharge rapidly as a consequence. And what that enabled us to do was transform and improve our discharge processes at pace. And we're particularly proud of the development of the hub, which enabled us to wrap services around patients who were either discharged from hospital or to keep them safe at home and prevent hospital admission. And indeed, that's something that we will be building on as part of our 2-hour response as part of the national plan and contract. Our trust strategy has always been to value patients' time and ensure that care is delivered in the right place at the right time, and that actually your own bed is the best bed. And certainly the board story that Russell's already alluded to this morning from one of our hospital at home teams gave an example of a patient that in 2019 spent over 200 days in hospital, but with their input spent much less time in a hospital bed in 2020, and actually felt confident and safe and happier at home. Clearly, there are some patients who need to spend time in hospital, and that's the right place for them. What we're keen to make sure is that those patients don't come to harm. So Jane alluded earlier to something called hospital-acquired functional decline, which is when patients potentially decondition in hospital because they're perhaps not as active as they would be in their own environment. And it's recognised that if you see long lengths of stay, delayed discharges or stranded patients, as they're now called, and high numbers of medically fit for discharge patients, then you're likely to see high levels of hospital-acquired functional decline. And as you can see in the report, the graphs demonstrate that we've got good performance in these areas. Our performance in relation to discharge to normal place of residence has always been good, and as you can see, it continues to improve. And our readmission rates to community hospitals, but actually also to the acute hospital, remains low, which is a good thing. What we're really excited about is the stuff that Jane's already alluded to, this collaborative working across primary care, secondary care, the local authority and the third sector to develop that community response to ensure that patients are cared for in the right place as part of our business as usual model to discharge and supporting our patients. I'll leave it there, happy to take any questions.
Thank you very much, Lucy, very comprehensive. Any questions or perspectives? If I can ask colleagues to use the chat function as far as possible, but on this occasion, please come off mute. Okay, thank you, Lucy, very reassuring. And it was great to see, as you mentioned, the hospital team this morning. We have, as we had a presentation before the public board went onto YouTube, to our Going the Extra Mile Award winners this month. We have some absolutely fantastic colleagues to the Wye Valley Trust. So moving on then, Andy Parker, thank you for standing in for John. Andy, over to you. Please tell us about how busy we are.
Thank you, Chairman. I will take the Chief Operating Officer's report as read. However, there are just 4 items that I wish to highlight. The first is Glenn and Jane had already mentioned around our elective recovery plan. Plans are progressing well for the Trust, despite challenges related to COVID swabbing and ongoing issues related to patient flow and staff self-isolating due to COVID restrictions. However, if we compare how the Trust is performing against the region, if we take our combined outpatient delivery compared to last year, we're delivering 81% of activity compared to last year, where regionally the region is performing around 75%. If we take electives, the Trust is performing 77% of the same level of activity compared to last year. The regional figure is 75%. For endoscopy, we are 55% compared to activity last year. Regionally, the average is 63%. A number of STPs are under 55%. However, we do have comprehensive plans over the next couple of weeks to improve that figure further. And imaging, we're 96% of activity compared to last year, where regionally we're at 85%. So a really good news story for the Trust in terms of delivering our elective activity plans to get us back to business as usual. Second point I want to raise is around the COVID second wave preparedness. Planning is concluding on our response and escalation plans, including looking at what triggers we need to implement and when we need to re-implement COVID positive protected areas, and also when we need to look at reducing elective activity and prioritising that reduction in elective activity in a clinical priority order, but which to release additional bed capacity, but also staffing to manage those additional areas. But also within that plan, we just want to ensure that our de-escalation and our return to business as usual is as rapid as our escalation. Divisional teams are working with HR teams currently and working on a plan for staffing increases where needed, but also how to support staff well-being, welfare and resilience, because that's obviously key. Along with that, we're finalising our winter plan document, which will be a staff-facing document available to all members of staff. And again, that will document not just the Trust's triggers and escalation actions, but our system partners' actions to protect our flow and safety. And the Chief Operating Officer will bring that back to the board next month. The third item is around the urgent care pathway, which the activity in terms of attendances and admissions are back to where we were in pre-COVID levels. But there are significant work ongoing around the urgent care pathway and front door processes. As we know, estates plans progressing to increase the ED and same day emergency care SDEC capacity to reduce overcrowding, corridor care and maintain IPC requirements. The ED is now working across an increased footprint, which is no longer blue and green representing the COVID split, but is a majors and ambulatory split across the same footprint, with a senior doctor, either consultant or specialty doctor, at the front door, signposting patients as they come in via their COVID screening to majors, ambulatory and SDEC. SDEC continues to improve significantly. September was the busiest month for SDEC, with 620 patients with a 0 length of stay. That's 80 more than our previously busiest month for same day emergency care, and equates to 38% of admissions. We've had success with some acute physician appointments, and along with the improvements to SDEC, we will have increased consultant presence within SDEC over the next few months, which will allow us to progress our virtual ward capacity with primary care through community EMIS, and that's scheduled for September. We've implemented last week direct hotline to an acute physician in SDEC for YMAS, and we continue to monitor that. On Monday, the Trust was part of a pilot with Worcestershire on 111 first, or early adopter, should I say. That started on Monday, and for the first 2 days, we've had 26 patients scheduled through pre-booked appointment in our emergency department. All bar one has been dealt with in 4 hours. We've had one admission, and of the remainder, they were either follow-up with no further actions, referred to their GP, or returned to SDEC on a future date for a follow-up appointment. And fourthly, which is breaking news, our stroke SNAP score for the quarter from April to June has maintained a B status, but not only is it intended or achieved another B status for SNAP, it has increased points as well. So it's our highest point score for a grade B that the Trust has achieved. So it's really good news again for the Trust and the patients. Thank you.
Andy, really good summary. Thank you very much. And good to hear that the update on stroke at the end, but really comprehensive and very assuring. Questions or perspectives to Andy? Please come off mute. No one's using the chat box. Okay, great. And oh, sorry, Jane.
Just one. I guess, Andy, I know it's very early days for 111, but do you have an anticipated time when those pathways might go round ED and to the SDEC pathways?
So SDEC is currently available on the directory of service within the 111 system. However, the clinical algorithm for NHS pathways requires an upgrade to allow us to allow YMAS to point those patients directly into SDEC. So at the moment, we are relying on our streamer at the front door signposting those patients through to SDEC. However, we have opened up the ability for the clinical advisor within 111 to contact our acute physicians directly between 8 Monday to Friday for clinical advice and support.
That's a streamer, not a screamer. Thanks, Andy. And question from Richard Humphries.
Yeah, thank you, Chair. I just wanted to commend colleagues for the work that they've done on the discharge to assess. And there's a whole raft of new hospital discharge requirements that we have to fulfill, which I think generally is good news. But this is really quite tricky stuff, as we know from the past. How you get the right balance between discharging people in a timely way, but also in a safe way and not too soon requires the judgment of Solomon, I think. And it's something perhaps we ought to keep an eye on as a board, perhaps through the Quality Committee, about how these new arrangements are bedding down. No,
absolutely, Richard. Very good point. Thank you. Okay, on the basis there are no more questions coming into the chat box, we'll move on. And Jeff, over to you on workforce, please.
Well, thanks, Ross. So in terms of the workforce report, we are still seeing good progress on the key performance indicators. So it's good to say we're still seeing good progress on that. And we are working actively with managers on outstanding appraisals. I'm really pushing on that. So I am hopeful that any outstanding ones will be completed this October before we get into winter. So few left, but we're working on them. As we get into winter, we will be launching the flu campaign on Monday. So I've been working with Lucy and Erica on this. So we're aiming to cover as many stuff as possible. And we're kicking that off on Monday. The final page of my report has a table which just gives an overview of key HR Audi developments. And we now have some strategic groups in place working with senior clinicians, occupational health, trade union colleagues on health and well-being, equality and diversity and stuff like that. So hopefully that gives you an overview of developments within HR and OD. Happy to take any questions.
Thank you, Jeffrey, and really great presentation this morning, Jeffrey, to the board workshop talking about your 5-year ambitions for us as an organisation on health and wellbeing. And I would say to members of the public who are affected by the current economic crisis coming out of COVID, who maybe have children who are looking as to what career options there are now available to them. This is a great time to apply to work in the NHS. We are interested in your character, we're interested in your competence, and you give us the raw materials, we can enable you and help you to have a fulfilled and very worthwhile career in the NHS. So please apply. I think, Chris, do you have a question, please?
Yes, thank you, Chair. Jeffrey, I was interested in the vacancies for additional clinical services and sick levels for that group are high. What constitutes staff within additional clinical services?
Right, I have another breakdown at hand, but it's certainly something I can provide to you. I guess Jane may be able to answer that. So
I think it's mainly healthcare assistants, Jeffrey. It's a funny term that you probably haven't got used to yet, but it's mainly healthcare assistants.
Thanks, Jane.
Okay.
And
Thanks,
is there
Jane.
something we can actively do about that, or?
Well, what we do is we certainly, as I said, we now have a comprehensive report on a weekly basis. We're trying to identify where the potential issues are. So trying to pick up with occupational health and line managers to see how we can support those areas. So we are looking into those areas more closely.
Okay, thank you.
I think quite high sickness absence amongst healthcare assistants is something Glenn and I see across the foundation group. The other thing that's often noticeable, Chris, which you'll be aware of, is the lowest sickness and absence generally is amongst consultants. Frank, question from you?
Yeah, if I can refer to page 48 of 150, the exit interview analysis, reasons for leaving. A bit disturbed that second in the table is other not known, which suggests we need to do a lot more work on making sure that interviews take place. But more importantly, the work-life balance one, quite high up the table, really feeds the aspiration towards flexible working. And basically just want to make that emphasis. Thank you.
Thank you, Frank. And I know you've been a big fan of exit interviews, helping to steer us in terms of HR policies. So I think Jeffrey will just sort of note that.
Yeah, thanks. Though, just to say, we also now have a more comprehensive process, which I will be able to share, hopefully, well, maybe at the next board, because on a monthly basis now, with effect from September, we're now doing a lot more work with people who live in the organization. So directors get to see a more comprehensive report. So I may be able to share some of that going forward.
Thank you very much, Jeffrey.
You've made that clear, Jeffrey, and I really welcome it. Thank you.
Thanks.
And any other questions or perspectives? Can't see anything coming up on the chat box. Okay, super. So we live in strange times on the money, Howard.
We do indeed. Please. Yeah, we do indeed. And this is the 5th month of what we might call the emergency arrangements, which were put in place following, as a result of the pandemic. So in financial terms, in many respects, it was a sort of fairly stable month. We've broken even again, but thanks to the application of this mechanism called the retrospective top-up, which has been an approach to ensure that all trusts are actually in a break-even position. This situation will change from month 7 onwards. So we have one more month of this sort of slightly unusual situation. I will be bringing the financial plan for the second half of the year to the next board. I will take the bulk of the report as read, but there were just 3 issues I did just want to highlight. Firstly, we have seen in August both nurse agency and medical agency beginning to creep up again, and I have noticed that in September that trend's continued, and last month saw the highest level of nurse agency since March. So it's something we've got to keep an eye on. I mean, obviously, as more activity happens, you know, it is almost inevitable, but that is an interesting and important factor. Off framework also is creeping up as well. In terms of capital, it was mentioned during the workshop this morning about the amount of capital. Again, living in strange times, so it's sort of, there's a real pressure on capital, and yet there are lots of additional extra capital resources coming out which we can bid for. We've been incredibly successful, and as you'll see from the paper though, that this year we are getting capital from a number of sources, albeit that a number of them still haven't actually materialized in terms of cash in the bank. And one of the issues that we are managing this year is this process of trying to make sure that we get as far ahead as possible on the capital schemes whilst still not actually having got our hands on the cash. And that's what those tables in the report are really highlighting. I would say, however, that in the last week, we finally received confirmation that we've received £670,000 worth of capital associated with purchases relating to the COVID outbreak. This is capital which should have been approved way back in May. And we've just had confirmation that we've got 670 of over £1 million worth of expenditure in the last week. The final item, which is in the report, but is actually strictly speaking September information, is that on the 16th of September, we had £193 million worth of loans converted to PDC, which is an issue which we have wanted to see the back of for a while. And it did leave us in a very, very strange occasion for one day only having £230 million in the bank. But that has now actually been paid back to the government. So I'm happy to take any questions on the finance paper.
Thank you very much, Howard. Glenn?
Notwithstanding the £230 million you had in the bank for that moment, Howard, how are you finding the interim arrangements from a cash management perspective? Is it easier than previous years because of?
Incredibly, Glenn. I think the Department of Health has made a big issue about putting lots of cash out into the system to make sure that payment issues haven't caused any delay anywhere in the system, and it is absolutely true to say that we've never had as much cash as we have in the last 6 months. It's really been quite good, and I think, as the report says, we have improved our payment performance dramatically. It was reported earlier this week that a number of trusts, despite the cash help, haven't, but I am pleased to say that we are doing really quite well on the invoice payments.
Yeah, and obviously it's important that we manage our cash well, but also it's important from an economic perspective, particularly payments to local suppliers, that's happening more rapidly. So that's good news.
Absolutely.
Thank you, Glenn. And any other questions from colleagues? Howard, if only every day we had 230 million in the bank. We'll move on. So we now have some items for approval regarding terms of reference of different subcommittees. Erica, do you want to lead us through this, please?
Yes, thank you, Chairman. As is our annual routine, we've reviewed the terms of reference of the Charity Trustee, the Remuneration and Terms of Service Committee and the Audit Committee. All of those respective bodies have reviewed the terms of reference, and they're now with the board for approval.
Okay, thank you, Erica. So we'll take them one by one. The Audit Committee revised terms of reference. Is everyone happy to accept? Please come off mute if you're not. Okay, on that basis, duly accepted. Thank you. The Charity Trustee terms of reference. Is everyone happy to accept and approve? Please come off mute if you're not. On that basis, duly approved. And then finally, the Remuneration Committee for approval, their adjusted terms of reference. Is everyone happy to approve? Please come off mute if you're not. Jane?
Yeah, there was just one on this when I read through it last night. Under the duties, there's a bullet point which says responsibility to review the level and structure of remuneration for senior management, i.e. the level below executive directors. And that isn't something that the Remuneration Committee has done. And because all of those posts are under agenda for change, it doesn't feel like it probably is appropriate. So I think we probably need to take that bullet point out.
Okay, I think Glenn's agreeing with you, and so do I. So let's make that adjustment. So with that one adjustment, is everyone happy to approve the adjusted terms of reference for the Remuneration Committee? Okay, super. That's duly approved as well. Thank you. The board committee dates for 2021, Erica.
Again, as part of the planning for next year, we've produced the suggested proposed committee dates. The only thing that item that I draw your attention to is that the January 2021 board date is slightly later than we would normally have them within the month, and that's to allow for the Christmas and New Year period.
Super. Christmas is coming. Whether we can meet or not, time will tell. Wash your hands, socially distance, wear a face mask, but it will be on the 25th of December and New Year's Eve will be on the 31st of December. Everyone happy to approve those dates?
Chair, just
come off mute if you're
minor
not.
point.
Chris?
It's Chris here. I think we're going to have to extend by half an hour all the quality committees. We're just struggling with the amount of papers, so that's the only minor change. Sorry, we only agreed that in the last week.
Okay, great, super. David, I do apologise. There's a point which has just come up on the chat box from you, which I missed. I apologise for that, David. Is it still relevant, or do you want to make your point now?
It's not really relevant anymore, Howard. Russell, sorry.
Okay, I do apologise, David. So is everyone happy to approve with the adjustment of the Quality Assurance Committee being extended by half an hour, the committee dates and the board dates for 2021? Please come off mute if you're not. Okay, super, duly approved. Thank you very much, Erica. We're then on to the digital programme update report. Howard.
Thank you. Yeah, just a couple of points I want to bring out of this. I take the report as read. It is fairly detailed, I think, now, and we have also reintroduced the RAG table, the red, amber, green table to monitor progress, and we've got it against each of the individual parts of the programme and some of the individual elements of the actual EPR project. I can report progress on all the projects, and I think it's also fair to say that a number of the slightly smaller outstanding or awaited issues which are referred to in the paper have actually now been progressed. I actually checked with project managers prior to the meeting, and I'm pleased that the outstanding things have been progressed. So I think it's a positive story on the whole. Specifically, I was just two other things to mention. One is in relation to EPR. I have talked about both the detailed implementation plan and the likely additional cost associated with that being brought back to the board. I am actually aiming for either the November or the December board for that. I think it's important that they come hand in hand. And the second thing is, the paper reports to the joint implementation plan. And this is something which we have been working on over the last couple of months, and I think it's come together now. This is actually to make sure that both the EPR project and the EPMA project are talking to each other, and we're actually going about implementing them alongside. And you'll see the concept within the paper about aligning the implementation of these two systems on the ward in what we've referred to as a digital month. This has been proven to work elsewhere. We are obviously doing it at a difficult time with COVID and with winter and with ward changes, but actually we still think that this is going to be the best approach, because what it means that we are working in an integrated, joined up way. But other than that, I'll happy to take any questions.
Thank you very much, Howard, and thank you for your leadership on this project. Frank, you had a question?
Yeah, this morning in Care at Home, we talked about digital monitoring. Where can we expect to see progress on that in the whole board structure? And what about other technological improvements? How can we keep an eye on things?
Right. Well, Frank, I mean, obviously, as we know, the whole of sort of technology and IT is a massive area. In August, we had a board workshop on the IT strategy, which should be coming back to the board again, either in November or December. We can't do everything because of primarily because of resource, but also you can't, totally submerge the organisation in new IT projects. However, having said all that, I think it's absolutely critical that we do actually look for the areas where it's going to have the biggest gain and make sure that we do try and make sure that those get priority into the top. So I think it is partly about ensuring that exec colleagues and board colleagues actually do contribute to that prioritisation process.
I think Glenn will want to make a comment about the digital hub. Glenn?
Yeah, exactly. I mean, there's a piece of technology that we're evaluating in the through the digital hub in the group at the moment, which is being deployed in North Warwickshire, which uses Wi-Fi to monitor patients with dementia when they're discharged home to see if they're going about their normal activities, and that's showing some really good evidence. So if that pilot works, our objective around the digital hub would be to roll out into group solutions as quickly as possible. So that is something that we could be using.
Glenn, just remind me, next week at the Foundation Group Board of Directors digital get together, are we having an update on the digital hub there?
I could add something. There's a bit of an action-packed agenda that it might be quite hard to squeeze into, but we could certainly reference something on it, Russell, if that's okay.
Yeah, I think that would be good. Sorry, I thought you were doing it under your sort of overview, but
yeah,
don't overburden it.
I will now.
Okay, wise choice. Chris.
Thanks. It sort of follows on a bit from Digital Hub. I was very surprised that GPs in Worcester can't access Hereford records, particularly radiology records of people who've been inpatients. And I just wonder where in our digital strategy that might fit in. Maybe I'm just expecting too much, but in this day and age, one would expect that we should be able to do that.
Glenn?
Yeah, I mean, Howard may be able to talk about something more specific, but there is a shared health and care record project, that is a summary care record project that's underway that actually covers Birmingham, Coventry and Warwickshire and Hereford and Worcester, and that would give us that access, and that's a live project that should be delivering for us within the next financial year.
Yeah, I think it's by the middle of next year, Jane. Jane, you wanted to make a point?
Again, sort of aligned, and there's also this initiative around the integrated care and wellbeing record, and I don't think it'll get to the point of having actual images being available, but certainly reports should be available through that. And I was just going to ask Howard to talk about how we're going to link that up to the digital programme board that he runs.
Howard?
Yeah, absolutely. I mean, so the project that Jane's just referred to is being chaired by the CCG and STP digital lead, and he and the project manager actually have been invited along and have actually started attending the monthly Wye Valley Trust Digital Programme Board, so that we can ensure that not only do we have a regular update, but we're actually making the links between systems and key stakeholders. So yeah, working hard on that.
I think, Chris, so just going back to your point, whilst there's clear progress, and Jane's indicated on the health and wellbeing record, there's still enormous gaps in integrated functionality between the different bits of the health and social care system. I can't see any other questions from colleagues, so thank you, Howard, for that update. It's clearly a big area of focus, and looking forward to the digital month when we get there. Colleagues, happy to move on to the policy panel. Erica, back with you.
Thank you, Chairman. You'll recall that last December we established a policy panel, and that adopted best practice of our group colleagues, with the aim of the policy panel just to have some consistency in formatting and a process by which the policies are ratified formally and provided to the board. So this just provides an update of those policies that we have approved recently, and I know that the policy team who report into Lucy are very much on the looking to maintain our policies to a consistent standard. So this list, I think, is going to be even larger next month.
Okay, great. Thank you, Erica. And it would be great, I think, as Jane would also concur, for the policy paper to link with the actual policies we've approved. So if we can make sure that happens. Any questions to Erica on the approved policies? Okay, super. Thank you, Erica. So we'll then move on to the Audit Committee annual report, which will take as read, given Andrew's absence. But Frank, is there anything you wanted to mention on Andrew's behalf?
Nothing in particular. Okay. It was very much taken as read and hopefully clear to everybody what we're supposed to do with it here.
Thank you very much. So any questions or perspectives on the Audit Committee annual report? Okay, thank you everyone for their work on the Audit Committee, and Howard for, if you like, feeding the machine with your team. We'll then move on to the Quality Committee of the 27th of August. Chris?
Chair, no, take it as read, but just to reassure board and members of the public, we've noticed an increase in mortality rates in the rolling 12 months in August, but can I reassure you that those have now reduced as we would expected they would, and so you will see that going forward. I just wanted to reassure. Thank you.
Thank you very much, Chris. Any questions to Chris? Okay, super. Thank you very much. We've then got the Audit Committee of the 17th of September. Frank, anything you wanted to add?
No, thank you.
Thank you, Frank. Any questions from the Audit Committee of the 17th September notes? Okay, thank you everyone for their hard work in that subcommittee. And then the Charity Trustee meeting of the 17th of September. Anything you wanted to add, Frank?
No, thank you.
Okay, and then any questions to colleagues on that? And then we've got on the agenda the Remuneration Committee of the 17th of September, but that actually didn't happen. So we'll pass over that. Then moving on to committee minutes of the Quality Committee of the 30th of July. Chris, anything you wanted to add?
No, thank you, Chair.
Okay, any questions to Chris on those minutes? Okay, thank you. The Audit Committee of the 18th of June. Frank, anything you wanted to add to those minutes?
No, thank you.
Any questions on those minutes? Okay, duly noted, thank you. And then the Charity Trustee meeting of the 18th of June. Frank, anything you wanted to add?
No, thank you.
And then any questions from colleagues? And the foundation group meeting of the 20th of July. Richard, anything you wanted to add?
Nothing to add, Chair. The minutes are fairly self-explanatory.
Okay, thank you. And any questions to Richard on the foundation group minutes of the 20th of July? Super, thank you. So any other business? Please come off mute if you have any other business. Okay, so we have no other questions from members of the public, but it's great that Chris has provided a question which I will read out and then seek, it's in as ever, a statement and then 2 questions. Just before the summer recess of Parliament, Jeremy Hunt asked a question of Matthew Hancock, which alluded to a best practice league table of English hospitals. Jeremy was concerned about the considerable difference between those near the top of the table and those nearer to the bottom. He asked what was being done to close the gap. Matthew Hancock's response suggested that he was aware of the problem and steps were being taken to deal with it. This raises the following questions. 1. Is it possible for members of the public to view this league table? If so, where and how? 2. What is the position of Wye Valley in the league table and what steps are being taken to ensure the Wye Valley consultants adopt best practice? 2 great questions, Chris, and Glenn will start off and I might follow. So Glenn, your answers, please.
Firstly, it's great to know Chris is out there and asking his questions in the usual style, albeit through you. I'm not sure of the precise league table that he's referring to, but of course there are multiple league tables available that compare the performance of trusts, and we usually bring them in some shape or form to this meeting actually, when something has been produced. In terms of mechanisms to improve performance, I think one of the most significant ones is what we're doing, which is to be part of a group where we're sharing best practice and benchmarking between the organisations. There's also a national tool that provides benchmarking from a financial perspective called the Model Hospital, which we've looked at before also. So I think group models are being seen increasingly across the NHS as a way of driving up performance. And we've highlighted over the last couple of years some areas where we could do better, and we set out to do better. And probably one of the most significant league tables that I always look to is the staff survey, and we reported back into the board the marked improvement year on year in our staff survey, and those surveys have just gone out again today, and we will be hopefully benchmarking and improved performance again in future years. But if there's a specific question on that, Chris, that you want to come back to me on, then please do. But we always try and bring such league tables to this public meeting.
Thank you, Glenn. And I would just add, in terms of the adopting best practice, a few points on this. The reason, if you like, Glenn and I set up the foundation group was to identify and share best practice at place. So there's a lot of work that goes on in terms of the foundation group. But in terms of consultants generally, one of the most important initiatives, I think, of probably the last 10 or 20 years within the NHS has been the GIRFT work, which takes different service lines and identifies best practice for consultants in terms of how a hip operation is done, or how a knee operation is done, or how any particular surgical intervention is done, and shows the variation. And then the GIRFT team visit different hospitals, and we have been the subject of those type of visits. So that's one of the ways that our consultants will be helped to identify and improve on best practice. And David, I think you want to make a point?
Also, Russell, we regularly get or receive NICE guidance technology appraisals, which we have to routinely benchmark ourselves against and confirm whether we're either adhering to best practice or if we're not, put in development plans so that we do.
Okay, that's great, David. And I think you'll confirm that Matt Hancock, I think, singled out Herefordshire as doing well in terms of our COVID response. That's good news. And Glenn mentions in the chat about the fact that the reference earlier to the stroke indicator is another example of league tables. So, but the issue of making sure that we're relentless in trying to improve the way we do things to have better practice, I think is a good challenge, Chris, and certainly one that all of us as a board are focused on. And as you'll be aware, we've done some great work in terms of our league table positioning over the last few years on the mortality reviews, which David has been at the forefront of leading for us. So that was the only question we had from members of the public. I really would encourage members of the public to send in questions to the future. And please do give us any feedback in terms of this YouTube format and the live streaming. You've been able to see little windows on the world to each of the different executive directors and non-executive directors, households or offices. So I hope you found that, if nothing else, interesting today. I look forward to seeing you at the start of November. In the meanwhile, can I please encourage you to have your flu jab, download the NHS COVID app, wear a face mask whenever you go out. Please do socially distance, and please do wash your hands far more often for over 20 seconds. In the meantime, take care. Thank you. Erica, if you can turn off